Nice of you to be here. We'll introduce ourselves since we do not have a moderator here. And it's actually very nice to get after Dr. James Gravestone, because I am going to talk to you about how to monitor a patient journey, both on an individual level and at an aggregated level. So I am KariAnne Vrabel. I am a clinical psychologist and a research leader at a psychiatric hospital in Norway called Modum Bad. Not Modum Bad. It's always difficult abroad to talk about my psychiatric hospital, but it's Modum Bad. And I'm also an associate professor at University of Oslo. So I have pretty much been professional grown up at this place at Modum. It's a nationwide psychiatric hospital treating patients with different mental health disorders and problems at residential care. So they have been receiving standard treatment without getting faring well or having a good outcome. So then they are applied to an admission at our psychiatric hospital. And our hospital, where we have it's a very intertwined collaboration between the clinic and the research department. So both the clinical leader and the research leader is part of the same leading group, and we both report to the director. So we deliver evidence-based treatment, and the researchers are pretty much actually clinicians working in the clinic as well. And we deliver treatment for affective disorders, eating disorders, trauma disorders, anxiety disorders, couple and family therapy. And most of the persons or the couples that are admitted are patients with trauma disorders. Okay, and we also have 2 outpatient clinics. So this is the team, some of them. We have 100 beds, we are about 300 employers. But this is some of the teams that have actually been working at Modum Bad for the last 25 years. And some of the persons at the pictures have been asking questions back then that is pretty much can be condensed to how to improve the outcome of our patient at our facility. And we also have recognized and affirmed some of the problems, especially in the psychotherapy field, and that is that the therapists estimate that 85% of the patients improve. So it's pretty much a win-win situation for the therapist. We think that our patients that we do deliver treatment to, or psychotherapy, are actually faring rather well. 90% of therapists believe that they are at or above 70% of the peers. So we also think that we're actually better than other therapists. And no therapist regarded their own outcome as being below average. These are, you can get into Michael Lambert, Bruce Vampel. These are persons that have actually been doing some rather great stuff and good studies when it comes to these findings. So we do not think that we are actually doing delivering treatment that are below average. However, 5 to 10% of adults and 14 to 25% of child clients deteriorate in routine care. So the problem is that we do not see them coming. So there are patients that are not doing well when we deliver treatment for them, but we're not able to interpret it or see it or be aware of it. So we actually, at our hospital, we started to ask these questions back in 2000. How can we try to find out this at an earlier stage and be informed by more than just our perception of the therapy process, but also be informed by what the patients actually are telling us? So we started up at a very simple place, and that was paper-based. So back in 2000, we started to ask the patient routinely at admission and discharge, and we also had a 1-year follow-up, where they were asking questions about symptom disorders, some of the processes that we think we are delivering and doing and want to treat in psychotherapy. So the patients were asking these questions, and they were handed over the questionnaires to us. That was actually a good start. We started on a journey in a way. But of course, lots of problems. It was problems with the storage. it was more randomly collected, who should make sure that the patients actually filled out the questionnaires. And maybe the biggest problem, it was a huge delay between the patients when they actually reported and also when the therapists was able to look into the data. So we actually wanted them to fill out at admission, and actually the clinician should have that information so we could make up a treatment plan. But because of this, it was long delays, and we maybe got it 2 or 3 weeks into the treatment, and then we already had started. So in 2007, we started with our own system. So we have some at our IT office. There were 2 employers at that time, and one of the IT persons helped us building our own, in a way, technical solutions. It was a huge leap because we now could move from pen and paper and into digital solutions. However, it was only the IT guy that was able to understand this system. So it was overly relying on one person, and also that person was not, his competence was actually not in building digital systems for how to monitor patients course. So it was a lot of failures, but of course we got lots of data into an SPSS file. So we was able to, dig into the numbers and the figures, but it was not easily accessible for the therapists to actually talk to the patients about it, have a dashboard, getting into the data, how to understand the course and things like that. So it was a leap, but we still had lots of problems. However, in 2012, we started a collaboration with one of the Norwegian suppliers when it comes to monitoring patient journeys and patient course. Then we started by actually not just asking the patients to answer questionnaires at admission, discharge, and 1-year follow-up, but at each week during their hospital stay. At that, having that done, we was able to prospectively monitor patient journey. How was they doing when it come to symptoms and also the processes that we wanted to work on in therapy during the treatment? And that was a new huge leap actually, because then it was very easily accessible for therapists. It was very easily accessible for the patients because they could now fill out the formulas on their cell phones or their devices that they opted to use. It was just a code and they were in, and we also had just a code and we were able to go in, and then we could have reports for all of the questionnaires that they were asked, or we could go into some of the questionnaires that was most interesting or important for the clinician. And we also had graphs that was easily understandable, both for the therapists and the patients. And they were not asking or had conversations when they talked about what does all this mean actually. It was really easily accessible. And because we started to doing that in 2012, we developed our own, what could you call it, assessment tool on the clinic. And this is what we have called Modum Process and Outcome Questionnaires. So these are plans for how the questionnaires fulfilling is for the patient. So they fill in questionnaires at Monday, Wednesday, and Friday. On Monday, it's the symptoms like anxiety, eating disorders, trauma symptoms. Wednesday, it's specific processes that we work on in therapy, like lots of affects and compassion, fear of compassion. And on Friday, it's pretty much the common processes. How are you doing with the collaboration with the therapists? And the patients, they are admitted at our hospital 8 till 12 weeks. So there is actually a rather huge plan that the patients are filling in when they're at our hospital. But we are using it actively because it's so easily accessible in the hospital. And I will tell you now just 2 short examples on how we're doing it, both on an individual level and at an aggregated level. So first, when it comes to evaluation of one patient. So it's lots of information. It's not that important, but the most important thing is that this is a patient with eating disorder that was admitted to our hospital. So these are the eating disorder symptoms. These are also depression symptoms that patients also had and fulfilled when the person was admitted to our hospital. On the y-axis here is the symptom distress, so the higher the worse. The dotted line is the threshold. And on the x-axis is the progressive week that the patients are admitted. So as we can see, when it comes to the eating disorder symptoms, the patients decreased rather fast some of the eating disorder symptoms when the person was admitted. However, it reached a plateau that it was really, really difficult to work on. And we also could see that by unlocking or challenging the eating disorder, we also could see actually from here, week 5, a rather decrease in the depression symptoms. And then we also went into the PTSD symptoms because the patients also had comorbid trauma. And then we could see that from especially week 5, when we started to unlock the eating disorder symptoms, it was pretty much clear that the eating disorder symptoms had actually dampened the trauma symptoms, because when we tried to work on that, the trauma symptoms increased. And if we also see some of that, this is the assessment seen through the therapeutic relationship. This is how the graph is looking. So this is the visual graphs of the patient's processes that the persons are fulfilling at Wednesday. So we do not need to go into all these lines, but this again is the y-axis, and this is the x-axis, the week, and we can see as the green here is the expectations when it comes to therapy. And when it comes to week 5, the expectations of the persons perceiving the therapy is rather low. And we know that when it comes to psychotherapy, it's really, really important that the patients feel hope and have great expectations for actually have a good outcome of the psychotherapy process. So this is actually a very big problem when it comes to psychotherapy and for these patients. So the rest, and I can show the last again, and this is also, the patients have high grief, high guilt, high shame, and high anger throughout the whole process. So what is this telling us? Well, this is actually telling us a patient that do not at this time actually have a good outcome. The thing is that this was very fast visible for us. So when we come to week 5, we understood that, oh, okay, here is something wrong. So we talk a lot to the patients, what is going on here? Do you actually, is this treatment too explosive for you? Is it helping you? What should we do about this? Maybe you should not have an eating disorder treatment at this moment. And the thing is that from week 5, we actually talk to the patients and try to help the patients at another care level after the treatment in week 11. So actually the patient should be at week 12. We finishing up the treatment at week 11. And then she had another treatment, and then because that's very often that they also are re-evaluated and re-hospitalized. And then we had a new hospitalization at a later point. I'm not going to have time to go into that graphs, but then we was more prepared. We knew that, okay, this is the problem here is both the trauma symptoms and eating disorder symptoms, and we need to help the patients have great hope and expectations of the psychotherapy process. So we were very much more prepared for the new admission. And these data and these graphs it was possible when we had this feedback to use these feedback instruments as decision making when it comes to the psychotherapy process for the patients. And I will also, the last example is a whole evaluation of a treatment program, more on an aggregated level, because when we have all these patients fulfilling all these questionnaires, we have actually now a rather huge database. So it's possible for us to go into the database and investigate how are the treatment program, what are the outcomes of the treatment programs. So we started up back in 2014 we reached out to Professor Glenn Waller, that's affiliated with the University of Sheffield here in UK, and also Ken Goss, the psychologist that's head of Coventry Eating Disorder Service in Birmingham in UK. And these are architected two different therapy models. So Glenn Waller is an architect behind the cognitive behavioral therapy, and Ken Goss the compassion-focused therapy. So we designed a study that looked like this. So there were patients with eating disorder and trauma, and they were block randomized to two treatment interventions. So either compassion-focused therapy or cognitive behavioral therapy. And because they were block randomized, we had patients that were evenly distributed, both like with trauma and no trauma in each interventions. And then we investigated the outcome after the treatment. And this is pretty much the summing up of the main finding of that study. So we found, because we had doing all these data collection, again, y-axis, symptom distress of eating disorder, x-axis, this is admission, discharge, and 1-year follow-up. The blue line here is the patients with eating disorder and no trauma, and the red line is the patients with eating disorder and trauma. And these are the patients that had been delivering compassion-focused therapy, and these are the patients that had been delivering cognitive behavioral therapy. And the main finding was that the patients with eating disorder and comorbid trauma, they had a relapse in the long term. So the patients, they were actually back, pretty much nearly back where they started at the end of the treatment. So after this finding that we have also collaborated with Glenn Waller and Ken Goss, now we have at our facility, we are delivering cognitive behavioral therapy for patients with eating disorder solely, and the patients with eating disorder and trauma, they have been giving compassion-focused therapy. And this we would not be able to go into that if we do not had monitored this really neatly. And the last thing about this study was that, of course, the sample has been randomized, and we looked into the admission and the discharge. The problem is, if we do not also monitor the journey when they are at our hospital, we do not know what has been working. So we also did that, monitored, we used the MPOC questionnaires, and then we found that for all patients, when we decreased the eating disorder symptoms 1 week, the self-compassion, that is a very important process when it comes to eating disorder and trauma, increased the next week. However, for patients with trauma in compassion-focused therapy, if we decrease the self-compassion 1 week, the eating disorder symptom decreased the next week. And this is actually very important, because when it comes to psychotherapy, we want to go into causality. We want to know that if I do this, investigate this process, try to do something about that, then I actually want the symptoms to decrease the week after or the session after. And when we have this kind of assessment plan, we're able to go into that. Okay, so summing up, the major advances that we have been had because of this process at our hospital is that we developed change-sensitive brief measurements. We have also had lots of psychometric studies. We have had development of expected treatment response, and we now also have method of predicting treatment failure. We have automated methods. We have possibility to do clinical trials. We have also been reducing treatment failures, improves outcome, and identified best practice. And also, very important to have people on board, it needs to be neatly. It needs to be easy, accessible, and with not many hiccups, because then we lose all the therapists. So that is very important. And what we are working on now, because we have this now it's embedded within our hospital in all we do actually. We have now 3 new important studies, and one of them is the network analysis that we are, and because we are doing that, we are able to personalize the treatment, that we do not deliver CFT or CBT for the patients, but we are actually doing a treatment model that is tailored for this patients. And we also have therapist development. So we use the feedback questionnaires, and now also the therapists are fulfilling questionnaires and are working on deliberate practice to train to be really good therapists, because we know that that's important in psychotherapy. Okay, Thank you. And then I'm handing the word over to Stig.
Thank you. My name is Stig. I'm the CTO and the CISO in CheckWare, who is the solution provider for Modum Bad. And it's very exciting to listen to KariAnne and how our customers use our software in good and clever ways to understand and learn more about their patients. And for KariAnne to make this happen, she needs the proper software, and that's what I'm going to talk a little bit about. So, CheckWare, we were established back in 2007 by clinicians who wanted to disrupt the pen and paper way of collecting data from the patients. And us being in Norway, it's hard to climb mountain, cross fjords, to go to the hospital, so you need to get this information from the patient's home. So that was one of the key elements when we started up here, and it was done in the mental health area. Throughout the last 15 years, our solution has been used by all the hospitals in Norway, a lot of clinics, private practitioners, municipalities, and all the ones who want to get the benefits of involving the patient as part of the treatment process, and also to offload some of the work from their own workforce over to the patient and build a strong commitment together with the patients through the systems. It's used within primary and secondary care and within mental and physical health as well. So, and you can do any pathway and any specialty. At the core of the system is that we have more than 1,300 copyrighted measures and assessments that are available in our system. And they include automatic scoring and ready-made scoring reports, which you can use to understand the state and condition of the patient. And of course, you can also build your own measurements, like the MPOC system with Modum Bad as well. So when you have the system, you need to integrate this. When you get a lot of volume, a lot of patients, you have to transfer the documents into the patient record system to make sure that this is safely stored and it's legally stored. So we have integration APIs that allows you to do this automatically as well. And then you can see all the reports that KariAnne showed you, they will be also available in the patient record system as well. So it's easy for the clinicians to find the information that they need. And when you do this change, when you use this kind of systems, it also allows you to rethink how you organize your staff to manage and serve the patients. And we do have a lot of customers that have documented that they can treat much more patients. We have 4 times, 6 times, 12 times more patients by simply restructuring how they serve the patients differently. And with the same quality of treatment, and some even with better quality of the treatment as well. And I think it's also very important when you think about the transition and the transformation of your services. It's not a one-direction communication, it's a bi-directional communication. So with our software, you can provide content and information back to the patient as part of the service. So this could be a mental health training program, it could be some other educational content, whatever it fits, and it can be triggered on the results from the patient throughout the data collections, so it's really tailored to the needs of the specific patient. As opposed to many of the solutions out there, which have hard-coded pathways, defined processes, and if you choose the product, you have to do it exactly the way the product dictates. We have a very different approach. We have a self-service transformation platform that allows your clinical staff to easily build and transform their services exactly the way they want it. There's nothing that are pre-configured in our solution. You just simply use it and start transforming your existing services. There's no need for a massive IT project or a massive resource-demanding project to establish a new pathway. It's a no-code platform. You just use these tools to build it on your own. and you can make it work the way you really want it. And I think one of the success criteria, at least for most of our customers, is that by having these easy-to-use transformation tools, they can move the projects away from IT and start using the clinical staff and build the systems where they really want to get the quick wins. The secretaries and the clinicians, they know where to start. They know what parts of the process that will really save them time, and it's easy for them to start in that end of the process. And I think over time we have learned that when you're doing a transition, think of this as a stepwise transition. Don't try to build this one massive service that do everything at once. Find software and solutions that allows you to do bits and pieces of the process over time. And to kind of show you how we think about this, if you look at the patient journey, it's a lot of steps and a lot of places within a service where you can start to getting benefits, and you can start doing the transformations. So in the screening part, you can get input to figure out what is the what kind of state is the patient in. Does it qualify for a service? Prior to the referral, you can identify what of the services fits best for the patient. You can add algorithms and tailor views in our system to help you prioritize which of the patients should be helped first and last. Also a very important part of the process. And of course, what you have seen with KariAnne, with a computer system, you can really measure the effect of the treatment that you provide, and you can use this as a control mechanism along the treatment process, so you can really get the best out of the treatment for the patient. And by using our design tools, you can individually tailor the process based on the response from the patient throughout the treatment process. You can make a more effective discharge. You can free up space much earlier. You can allow the patient to do the wrap-up from home, so you can get the beds open up earlier. Of course, what we see a lot of our customers do is that they now is able to follow up the patients after the treatment is done, after they leave the door at the clinic. So 3 months, 6 months, 12 months follow-up. That's very common, and it was hard for them to achieve before such a system. Our system will just manage the process for them. And of course, it's been a lot of talk of virtual wards and remote monitoring. For us, it's kind of like the same. It's about placing the patient at home, measuring what they're doing, and if there are thresholds that are surpassed, you have to get a notification, and then you can contact and follow up the patient. But you need to have a system that really tracks this, so you are sure and the patient are sure that they are really followed up. What you also see a lot of the customers that we have is that they integrate the research, and especially the recruitment of the research, as part of the treatment process. So they can use our system to trigger new recruits to their research projects. They can use the built-in consent modules to get a digital consent from the patient, so they can use the data in the research. And of course, the data exports that are in our system, it's built in our system. You can get SPSS pre-labeled files with all the variables you need straight out of the system. You don't need to talk to any IT guys to get the data out. It's all available from the application. And this is, of course, integrated. Just you can do it for automation, have other systems, triggers events in our system, but also to transfer the clinical data back to the EPR systems as well. So it's not difficult. We have a very easy to use visual design tool. So it's a drag and drop environment. You just draw the process. You can add multiple branches with decision points. You define the thresholds. You know best how the service works. So you build the system on your own. It's not something that we in CheckWare do. We just help our customers use the tools, and then people like KariAnne and the people at her clinic, they will use our system to kind of create the pathways and the services that they want, and the bits and parts of the services that they want. And as opposed to, I think a lot of what we hear from our customers, instead of searching for new software products that fit with a specific specialty or within a specific discipline, with the CheckWare system, you just create as many pathways as you want, as many flows as you want. You use the same system. You integrate once, and everything is always integrated. You can tailor the user interface to fit with each of the services, so you can have the behavior of the application will be different depending on what kind of service you're working with, both for the patient and also for the clinician as well. So you get a full end-to-end experience of each of the services. So it's a very good way to really get quick results very fast, and there's no need for this huge project to get started. So I think I will just leave you with some take-home points here. We are available in the stand. KariAnne will also be available afterwards if you want to see the system or test it. And I think that for me, the most important part, I think, with you guys starting to transform a lot of the services that you're working with, it's not something that you do once. Transforming a service is not like a one thing happening. It's a continuous improvement. And I think it's wise to find software and solutions and suppliers that understand this process and is capable of helping you find the sweet spots so you can start gaining resources and gaining traction. You can learn using the system, and you can start growing into a more digitized transformation. But don't get started and think that you can convert everything at once. It's not a good practice. I think this is why Modum Bad is still a very happy customer after 12 years of working with CheckWare, and we do have a lot of very satisfied customers that are continuously building new services and offering new services to their patients. So that's it from me. Thank you.